ready to go.
Good morning, everyone. Welcome to the September meeting of the Universal Health Plan Governance Board. I'm Helen Belanca, I'm the chair of this board, and we will get started with roll call and introductions.
Okay, good morning, everyone. Our roll call question this morning is, when you were a kid, what did you want to be when you grow up? So we're going to start with Helen Belanca.
Everyone, Helen Belanca, and definitely a teacher. I think you just said that I would love to be a teacher.
Debbie?
Debbie Ian's present, and I wanted to be a veterinarian.
Amy Fellows?
Amy Fellows, I don't honestly remember, but I'm not a teacher because I was raised by two educators.
Michelle Glass?
Good morning. When I was a kid, I wanted to be a librarian.
Bruce Goldberg?
Present, when I was a kid, I wanted to be an airline.
Judy Richardson?
Good morning. Judy Richardson. When I was young, I wanted to be a zoologist.
Welcome, Cheryl. Cheryl, what did you want to be when you were a kid when you grew up?
A teacher.
Welcome, Chenwei. When you were a kiddo, what did you want to be when you grew up?
Actually, also teacher.
Thank you. Oh, and we're adjourned. My goodness.
Thank you. Warren George. When I was 10 years old, I had to stand in front of the class and say what I was going to be. Wanted to be a bridge engineer, wanted to be anything else. Then when I graduated from high school, civil engineering. And by the way, when I was young, Tommy McCullough, the designer of the big Oregon bridges, he was my hero. Then I never made it into civil engineering, ended up as an industrial engineer, 40 years in titanium. And near the end of my career, I was touring with you and they were experimenting. Oregon Department of Transportation was experimenting with ways to save old bridges and find some carbon fiber that wasn't working, right? I think you should try titanium. And anyway, long story short, they got grant money, perfected the product, and now at least 15 Oregon bridges are old bridges are in place. It's a product I designed for protecting all bridges, including a number of finding McCullough's bridges. That's a long story, but I think it's good.
Thank you, everyone.
Okay, thank you. So a quick agenda review for today. Today we're discussing the role of vice chair on our board. We will be appointing our new committees, which is very exciting. And then after the break, we'll be having a presentation on the OHA Healthcare Cost Growth Target Program and discuss the outline for our first report to the legislature. So a couple of opportunities for discussion, a couple of things to approve today. As always, I want to take a moment before we get started on the agenda to thank those members of the public who have taken the time to communicate with the board through our public comment process. We really appreciate you submitting your written testimony. This month we received a lot of public comment. I'll go through these quickly, and please forgive my mispronunciation of your name. My best. So Mark Weiss from Mid-Valley Healthcare Advocates urged us to build a financial plan. Dr. Michael Huntington from Physicians for a National Health Program urged us to think about how we will finance our plan and whether the Oregon Health Authority is overstepping its role. And also suggested that perhaps we were interpreting public meeting laws too strictly. Karen Christensen from Mid-Valley Healthcare Advocates urged us to develop a financial plan immediately and reminded us of our timeline. Linda Creature, apologies, from Mid-Valley Healthcare Advocates urged us to develop a financial plan and asked us to reconsider creating a work group to identify some basic assumptions for the Finance Committee. And then Thompson Six submitted both written comment and asked to provide oral comment, which he will be doing at the start of the meeting. So I will allow him that opportunity for comment when we get to that agenda item. So in response to this public testimony, I just want to say unequivocally that the Oregon Health Authority team members who work with this board are in no way overstepping their role or undermining our work. On the contrary, they've been really great partners in developing our strategy and providing context and resources to us for both board members and staff, and we're really grateful for their involvement. OHA, of course, has led Oregon's healthcare reform efforts and expanded care to Oregonians in so many ways over the years. And there's just no way we could do this work without their support and involvement. So I just wanted to make that clear. And then secondly, the board clearly understands that a financial plan is our highest priority. There's everything that we do is centered around creating a financial strategy for this universal health plan. We also know that the 9 members of this board do not have the expertise to craft such a plan. And so we need to engage experts and members of the public. So our priority has been to establish a finance committee and launch that as quickly as possible. And then to work on getting an RFP out the door so that we can hire a contracting firm to do that work for us and with us and establish that financial plan. That work has been heavily prioritized. I think it's gone very quickly. I'm really grateful to our staff, Morgan and Jenny and Katie, because getting the committees up and running and getting that RFP out the door is a tremendous amount of work, and I think it's happened really quickly. So that's where our focus has been. Okay, so next on the agenda, we will be approving the minutes. Is there a motion to approve the minutes from our August meeting?
Move to approve.
Second.
Oh, any discussion?
Thank you, Helen Balaka,
Yes.
John Waichi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Chris Goldberg,
Yes.
Judy Richardson,
Yes.
and Cheryl Ramirez.
Yes.
Okay, great. So now we're going to take a few moments for public comment. I'll remind everyone that the board decided at our last meeting that if members of the public wanted to make a comment on an agenda item that we would be discussing or deliberating on, that we wanted to give folks an opportunity to make their comments known at the beginning before we had that discussion, so that we could consider those comments when we get to that agenda item. So we have 5 minutes now for public comment. We have 2 folks to speak. We have a 2-minute timer, and I will hand it over to Tom Sinsick for the first part.
My name is Tom Sinsick, I'm a retired nurse practitioner. I am speaking with concern about the work of the Universal Health Plan Governance Board is being sidetracked. The time spent talking about various payments methods last meeting is a part of that concern. My sense is that the report on the cost growth target brings no added value unless it shows that the pathway is affordable, accessible, and equitable. But that does not lie in the cost growth target work. I have attended a number of those meetings, including the previous committee that set the cost growth target. There's nothing in their hours of work that says they can deliver a plan of affordable, accessible, equitable healthcare. The cost growth target work does not operate under the values and principles adopted by this group. Let's make sure that the 40-minute agenda item on the cost growth target presentation by OHA is not an unnecessary waste of the board and staff time. The time could have been better spent focusing and organizing the work of the committees and continuing discussion of the revenue sources known to be discovered and undiscovered. Perhaps time hearing the expertise of Dr. Chi, who helped design the universal healthcare system. This was why the criteria for the board was created in the bill. It is the work of the Universal Health Plan Governance Board to deliver a plan to achieve the goals of affordable, accessible healthcare. Reports have been delivered to the legislature in 2015. The RAND study and the task force in 2023 showed that everyone can get care for lower costs. In essence, this work is to meet Oregon's constitutional fundamental right to health care. It is time to recognize that this is a time for transformation and not one modeled on the cost growth efforts work within the current failed system. I am curious about how this item got on the agenda in the first place. You know, that's kind of the issue of the sidetracking. Thank you very much.
Thank you, Matt. And then Dr. Tony German is virtual. Go ahead, Tony.
Yeah, thank you, Chair Blanca and board member. staff, for all your contributions in transforming healthcare in Oregon. I wanted to reflect on legislative intent of SB 1089 today. Many advocates and healthcare policy experts see opportunity in your work for simplification of a system that's too complicated. The origins and the path to the governance board are linear. SB 770 and the Universal Healthcare Task Force set the stage for the next steps in the work ahead, focusing on a unified financing system. And why? We as a state have taken many initiatives with specific legislation as the cost growth target program you're going to hear today, healthcare market oversight, Oregon value-based compact, patient-centered medical homes, and primary care reform, all really important ideas and specific legislation. However, those are not Senate Bill 1089. Many of you might be familiar with the Commonwealth Fund Health Insurance Survey. The survey, this serves as a reference over the last 15 years of health reforms, and they ask a simple question. Have healthcare costs prevented you from accessing care? And the questions are as follows. Have you skipped a provider visit, not filled a prescription, or avoided a recommended test or treatment due to cost? In 2010, 41% of people responded yes to these barriers. The most recent survey of respondents reported 46% find it hard to get the care they need, an increase of 5%. We implemented the Affordable Care Act with expansion of Medicaid and a robust subsidization of marketplace products and a continuation of employer-sponsored insurance. We should measure incremental reforms and be clear on the data of those outcomes. I'll leave my details in my written comments, but in the interest of times, simply add that the body of work of other programs differs from your work. You have the responsibility of moving past these incremental steps. A simple call out is that many of these programs have not met the anticipated benefits. Cost growth target at this stage has not achieved its goals despite its passage in 2019. For the value-based compact, the recent report of OHA reported around half of the insurers that signed the commitment didn't meet the stated goals. Many health policy leaders grow concerned that your valuable time is being distracted by other legislation or incremental reforms in the state. And the work of the governance board should be to develop a unified financing system. Thank you.
Thank you, Tony. Appreciate it.
Can I ask Tony a question?
Sure.
Hey, thanks a million, Tony. It's Bruce Goldberg. So I know that you're on the Oregon Health Policy Board. And I'm wondering if you would opine about the best way for this board to interact with the Health Policy Board.
Yeah, I appreciate that comment, Bruce. Oops, sorry, I think there might be a little feedback there. You know, I think I won't speak for the policy board, but I think there's valuable interest as a state in your guys' body of work. We're trying to be creative as a state. We're trying to be innovative. And certainly your work is incredibly innovative in taking a different pathway. It's my interest personally, and I think in my recommendation to my chairs on the Oregon Health Policy Board is to be aware of your guys' work and be supportive where we can, in an interest that Governor Kotek and that of our shared goals of the Oregon Health Policy Board moving forward to improve health equity in our state certainly aligns with the work that you guys are doing. So I appreciate that, Bruce.
Thanks, Tony.
Okay, now I'm going to turn the mic over to Morgan for the executive director report.
Thank you, Helen. There are a couple of things that I'd like to share, just some of the work that myself and staff have been doing since the last meeting. Really, we've been focusing in two primary areas. One, bringing in additional capacity to support this board and to support the work plan. We've been working with OHA so that they can hire the 2 full-time limited duration positions. There are 2 policy analysts that will be coming on board. One has a start date of mid-October, October 14th. We're really excited for that. And then the OPA 3, the other policy analyst is still in the works, but should be also having a start date very soon. And, you know, while those 2 positions are still working on kind of coming on board, we have been working with Devlin Prince and Laurel Swerdlow, who have been really helpful and as Helen mentioned in our work. I'm very happy to announce that we have signed the interagency agreement between OHA and the Universal Health Plan Governance Board to access the OHA Technical Assistance Bank. And Health Management Associates will be supporting us and supporting the committee work and also supporting some of the additional health policy research and research around federal waivers so that we can move some of that research and background work along while we're working on the larger RFP. As an update on that larger RFP, we have received the delegation from the Department of Administrative Services, and I'm working with the chair and the vice chair right now on finalizing that statement of work. We very much realize that the clock is ticking and are working very hard to get that out so that that solicitation can become live as soon as possible. And I believe we're still on track for the timeline that we talked about before with a contractor coming on in January, February, which is why that TA bank and that interagency agreement is so important as we work on that RFP. While all of that is happening, we've been in discussions with bringing on a contractor to support the community engagement planning. And there's a meeting with the chairs and the potential contractor. We're still working on the nuts and bolts, but I'm very hopeful that we'll be able to announce that shortly. In addition to all of the work to bring on additional capacity, the other focus has been on standing up the committees. I think we shared, we received 166 applications for the 4 committees. The staff for the governance board reviewed every single application. We developed a scoring system and scored every application. And then we worked with the chairs to identify a group of applicants that would be good and bring the subject matter expertise to those committee areas. And you'll be talking about that in more depth, but that was a huge amount of work. And we're just so grateful and thankful for all of the members of the public who expressed interest in sitting on those committees. While we are, you will be approving the committees today, we've also been working on setting up a committee orientation. So next Thursday, we'll have we'll have 2 sessions, one during the day and one after 5 for just some basic nuts and bolts across all of the committees. So that will cover some of the work plan overview. It'll also cover some nuts and bolts around public meetings law and public records retention that will be helpful for all of the committee members, but will not be kind of subject matter expertise in a specific committees. Each committee will still need to do some level of orientation specific to the committee. And while all that is happening, staff has been working on developing draft work plans for each committee. So as those committees go up, we will know kind of when we need to have that background research, presenters ready to go, and we'll be working with the committee chairs on finalizing those work plans prior to the first meeting of those committees. So a huge amount of work getting those committees supported and to get up and going as quickly as possible. In addition to the work that we've been doing, we have received some questions that I just want to share. We continue to get a question about if the board has enough money to do the work to accomplish the goals for a comprehensive plan to finance and administer a universal health plan. I think I shared at a previous board meeting. We have submitted a current service level budget within the DCBS budget. That budget is $1.9 million. That will continue the level of capacity we currently have in our staffing. So it will fund the 3 staff. And then there are inflationary increases in some of the other buckets like contractors. So it's slightly more money for contractors than we have this biennium.
Question about that?
You want
Is
to
that-
questions or wait to the end?
Yeah, sure, go ahead.
So Morgan, I get that. I understand the state budget process. We got 1.9 million, it gets rolled up, we go forward, blah, 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 blah. My question is more, and it's actually to all the board. That what's the budget that we need to do our work? I understand that's the budget that's been put in, but it's not based on anything. It's based on someone's finger in the wind. I guess my question to the entire board is, what do we need to do the work? It may be a lot less than that. It might be 5 times as much. And I think that if we're gonna get this work done, particularly going into a new legislative session, it would be really important for us to figure out what's the budget we think we need. We may never get that, but to just go along with what's in essence a plug number doesn't make a lot of sense to me.
Sure. I think that, to your point, I think we need a little more information about what we need for what we actually need. And, as we're designing the request for proposal for a potential contractor, we're, structuring it so that there'll be deliverables in there so that we can get a sense from a contractor what each of those deliverables might cost. And that will help us get a sense on if we have enough money. If we don't, we can take elements of the RFP out and come back to the board and say, we know we need more money to do this body of work. And then we'll have more information. When the agency was doing their policy option packages, which is, as you know, the formal structural way to ask for more money, the board was just getting stood up with the work plan, and it seemed too early to say even what that work plan had in it. So I think that we should continue to keep our eye on that. And as we get more information, I can bring that back to the board to inform a discussion about the needs.
I would think at some point in the next few months, we should, as a board, it'd be a good agenda item for a meeting to land on what you think is gonna be needed.
Bruce, are you talking about going to the emergency board or the next session?
I don't know until I know what it is we're contemplating. I think once we know what we're contemplating, we can then figure out a strategy of what to do. And when we need it, likely not the emergency board, it would likely be through the legislative process next biennium.
So Cheryl and Amy, are you responding to Bruce?
No, I have my thing up.
Okay. Amy, you want to respond first?
Go ahead.
Or I think what Ruth's is saying is right, and like one question is what we currently have in that 1.9 million, just the staff and contractors. But we're looking at things like, this is for the next 2 years. Through like the community engagement and communication committee, I can see things like, doing some kind of focus groups in different communities where we might need to rent a space, we might need to provide food, we might do some kind of communication, advertising, like I don't even know what the things are. But if those are the only line items in that budget, then, then we're leaving a lot out.
Yeah, and I'll respond also to, there are so many unanswered questions about our work and what we need to do and what lies ahead, and what resources we have. We don't have the time during these board meetings to kind of get in the nitty gritty, which is why we established the committees. So the finance committee is gonna have some information to start with, and then they're gonna have a bunch of questions, right? And they're gonna need to know, like, how do we get this information, or we need this to move forward, or, So and same thing with communication and community engagement. I think each committee is gonna have to grapple with the deliverables we're asking you to come up with and what it might take to produce those deliverables. And my charge to each of the committee chairs is really in your first couple of meetings, I want you to think through those things really carefully. Like, what are the deliverables that are expected on what timeline, and what resources do you need? How much money do you think you'll need to have the expertise on the committee? Do you need an outside consultant? We need to start narrowing down those needs, and we don't have the capacity to do it as a whole board, but we're relying on the committees to kind of get very specific on the questions that remain, and come back to the full board with a request. And I think once we get feedback from each of the committee chairs about where you see the work going and what the needs are, we'll be able to better estimate how much money we as a board need in full, and if we need to be asking for more. So I think that the onus is on each of the chairs. Does that make sense? Okay.
And I think that's been the missing piece is having, where is the conversation about what we need? And I think with that, we're trying to develop a plan to what we have. And then as the committees get started, if there are additional needs beyond that, I think that then bringing that back to the board makes a lot of sense. And I would recommend prior to the legislative session in a November, December board meeting, so, or, yeah, November, December would be the right time so that we could discuss it, kind of get ready for the next session.
Quick follow-up.
Okay.
One potential big item, and that might be costly, is to update and ultimately for the finance committee to come up with two numbers. One is the annual cost of the universal health plan, and two, how we finance it, how we tax that. So these two potentially might cost a lot because we need expertise to estimate. And previously we had contracted study, but that information may need to be updated.
So Cheryl, do you want to jump in, or Morgan, do you need to finish, or?
It's not about that.
Oh, okay, yeah, so.
Can I have one more piece of, some questions we've been getting are about the, public meetings law and the, changes, that are, reflected in our policies and procedures around board member communication. On, September 20th, the Government Ethics Commission will be holding a special meeting. One of the agenda items is to approve the administrative rules around the House Bill 2805 that created those changes in the 23 legislative session. I'll be working with Jake Gill, our attorney, to look at those administrative rules and see if there are any changes that would be recommended to our policies and procedures. One thing that we know will not impact the board, but the required training, one of the elements is that all boards and commissions need to have training on public meetings law. The administrative rules that are drafted say that it's required training for boards and commissions that have annual budgets of over $1 million. And it's recommended for boards and commissions that have annual budgets of under $1 million. So that would put this board in the recommended slot, not the required. I've still reached out to the Government Ethics Commission to put you all on the list to get the training, but it will probably be a lower priority. I think you also received some information from the governor's office. They're trying to also figure out how to get all of the boards and commissions trained on the changes to public meetings law. So more to come on this one, but I wanted to give you an update of where it is right now.
Or the training we did doesn't count.
The training that you did was not specific to the new public meetings law, but was a good training.
My question is about the committee orientation. I thought I read somewhere that it's not mandatory for board members to attend. I do have a scheduling conflict that day. Is that right?
That is true, yes.
Okay.
It is not mandatory for you all to attend. It won't be anything new for you. If you wanted to stop in and say hello, you're welcome to. We have Helen and Warren kind of giving some of the overview pieces and background on the preliminary structure that you all approved, and Warren will be talking about the joint task force. And then I'll give an overview of the work plan. And then, as I mentioned, we'll talk about public meetings law and public records requests and retention. So it'll be very, it'll be a little bit of information about a lot of topics.
Then I have a couple of questions. So Morgan, you mentioned there will be 2 new hires through OHA, our policy analysts that will be partnering with our work. And correct me if I'm wrong, but the role of those 2 staff members will be in great part to support our committees. Is that right? If we need help with researching, creating a policy brief on what's been done so far, or help with sort of understanding information that we might need of what's gone on at the state. So what are the current Medicaid benefits, or you know, what do we know about, you know, this topic? They could help and support the committees with that background and research work. Is that right?
Yeah, they are on the team that will be supporting the committees. We also have health management associates. So I think depending on the topic would depend on who would be the best person. And that's a lot of the thinking through the committee work plans that we've been doing with OHA, the DCBS staff and OHA have been meeting to kind of look through and say like, oh, here are the topic areas that make sense for the OHA policy analysts. So I think it's kind of like a little more nuanced than just like they're there, kind of just support some very specific work. And then we've got, as I mentioned, health management associates and Jenny. So we've got like lots of policy analysts and expertise that we can bring to support the committees. Yep.
So my second question is, will we have an opportunity to meet the HMA?
Yes, yep, they are, they started attending our meetings yesterday, or earlier this week. And they wanted to be, they are here.
They are online participating if you did want them to introduce themselves.
I would love that. They are, have a national conference, retreat this week. And so we weren't sure that they were going to be able to attend. So if they're there, that would be wonderful.
I think if you just want to call my name, maybe, call me by name and then they can come on mute.
Janine and Anya?
Hi, I'm Janine Smith. One of the HMAers with Anya Wallach. And it's a pleasure to be part of this group. I previously helped on the task force and know many of you on the board. So it's wonderful to be back working with you. I have past state health experience of the having been at the Oregon Health Authority for 15 years, working under Bruce for some of that time. So been actively involved in a lot of the universal healthcare work over the years when I was there, as well as working with the Washington State health, universal health coverage work as well. And Anya.
Hi, I'm Anya Rader Wallach. Great to see you all, even though you're teeny tiny. I joined HMA in April of this year. My background is almost entirely in state health policy, mostly in the New England states. Although I did live and work in Oregon back in the mid-90s for a while. I worked for state government and then I worked for Providence Health System. I currently live in Rhode Island, but I'm from Vermont. And probably my most relevant experience to this project is that I worked on something very similar for the governor of Vermont 10, 15 years ago, a universal health plan that we tried to get through the legislature and ultimately didn't. But I've also done high-level work in Rhode Island as exchange director, Medicaid director, and acting secretary of HHS. And hi, Bruce. I know Bruce from some of my former.
Glad you're a part of this as well, both you and Janine. It's great.
Thank you.
Yeah, on behalf of the whole board, we're so grateful to have both Janine and Anya on board to help us with this work. Thank you so much for your willingness to participate, and we really look forward to working with you. And thanks for taking a few minutes to introduce yourself today. We really appreciate it.
Thanks. It'll be fun.
Thanks. Yep.
Okay. So our next agenda item concerns the vice chair role. I'm going to turn it over to Warren.
Thanks, Helen. Besides wanting to be a bridge engineer, one of my main goals in life is when I get to the end of my life, my 8 to 6 year good time. And so we celebrated our 50th anniversary in August. As part of that, my gift to her is to still be involved, but maybe in a little lower level. I was scheduled to leave the board at the end of 2025. Moved that up to November 1st of this year. Very much appreciated this opportunity to serve on the governance board with you. And I particularly want to acknowledge Ellen and Morgan for our wonderfully arduous planning sessions. Thank you both for your dedication and for your personal friendship. I will continue, filling my board responsibilities until my departure date. The board will need to elect from, among our members a new vice chair who will take over, on that date. Our policy and procedures document basically spells out the role of the vice chair as conducting board meetings in the absence of the chair, working with the chair and the executive director on planning for board meetings and a couple of other things. I believe in a universal care system that provides adequate care to all residents under one transparent, easy and efficient system with no individual obstacles to member care. And I wish you all Godspeed in achieving that goal.
So I think I speak for everyone on this board when I extend my deep gratitude to Warren for all the work you put in, both before this board convened and in the 6 months that you've served as vice chair. Your expertise, your insights have been incredibly valuable, and we're really grateful to you. So thank you for that. And of course, we hope that you'll stay involved as much as feasible. And I want to encourage all of you. I'd love to have any of you step up to serve as vice chair. So I'd like to encourage anyone on this board who's interested in the role, please reach out to me. We can talk more about what it entails one-on-one, even if you just have questions or maybe you possibly might be interested but aren't sure, just reach out and we can talk about it. And I'll turn over to Morgan about the logistics of the transition.
Sure. So, as Warren said, he's, in this role until November 1, which means he will continue to be vice chair until he's no longer on the board. But we talked about having an, election at the October board meeting, so be thinking about it for October, and then the new vice chair would just take over for Warren starting on November 2nd, after he was, done with his term. This will create a temporary vacancy on the board. There are board and commission reappointments in December, but there's no opportunity for new board appointments through the appointment process that we need to use governor appointed and Senate confirmed. So the earliest opportunity to fill the seat, not the vice chair role, but the seat would be in January, February. I'm working with the governor's office on that date and timeline. We will be working to put information on our website about the vacancy. Warren's seat is a public engagement seat. So we'll have information and then can kind of answer any questions that people have about that, but also refer people to the governor appointments boards and commission site. There have been some questions early on about if people applied for this initial board. Apparently applications are good for 2 years. So if you applied for this initial board, your application may still be good, but you might want to go into Workday and just update any information on there. And then we'll be working with the governor's office to meet their timeline and expectations. So more to come on that.
Are there any questions or discussions about this transition?
Yeah, I had a lot.
Actually, I have a question for Warren. Are you gonna stay on some committees as a civilian, so to speak?
If some opportunity came up there, it's certainly any role that was appropriate.
So I think your knowledge would be great to have you continue on as a citizen member of one of the committees, not a board member. But I would leave that up to you if you have the time.
You want me on your committee?
You'd be on my draft card.
Thank you.
Okay, great. So we're moving on to our next agenda item. We're slightly behind schedule, but I think we'll have enough time before the break to cover this. So our next agenda item will be appointing our new committees, which is really exciting. And before we start, I would first like to echo what Morgan said earlier and just sincerely thank all the members of the public who applied to these committees. We had an incredible array of talents that applied, and it was so great to read all of the applications and see how much interest there was around the state in participating in our work. So a sincere thank you to everyone who applied. We did mention in our communications to all the applicants that, as we were saying earlier, we kind of don't know what's down the road for us. We don't know what our needs are going to be in the future. We may have new committees. We may need to add members to our committees. And so with all of the applicants' permission, we're hoping to hold on to your contact information and your applications. And we may be reaching out to you as the work progresses and we need to continue to add expertise. So we're really grateful that you've made yourselves available for that. Second, I really want to give an enormous thank you to the staff. Morgan already talked about how she and Jenny and Katie spent so many hours reviewing every application and coming up with a scoring system, and then advising the committees on the most suitable applicants. And it was a ton of work, and we really appreciate it. Thank you so much to all three of you. For the board, during this agenda item, I'm going to be reviewing the key tasks for each committee, the board members who are currently on the committee, and then the deliverables, just to refresh our memory about what the task of this committee is. And then we'll be able to vote to appoint the new members from the applicant pool. If any board member has a concern about any of the applicants or has questions, please make that known during this process. We have a process in place to then consider that sort of offline and come back to it later. So if there's any concerns that are raised as we go through this, please make them known and we will address it. Okay, so first up, we have the Communications and Community Engagement Committee. There are 2 work streams here, so there's going to be 2 slides for this committee. The communications objective for this committee is to develop plain language materials and materials in additional languages to communicate the work of the Universal Health Plan to the general public. They'll be developing messages, talking points, one-pagers, any kind of communication tools that they feel necessary, and as well as a comprehensive communications plan and some presentations. And then if we can go to the next slide briefly. The second objective of this same committee is community engagement. So to listen and engage with interested parties and communities throughout Oregon before, during, and after the plan development process, specifically to work with businesses, both large and small employers, help the healthcare community at all levels, and community-based organizations, as well as our federally recognized tribes and other existing boards and commissions. We want to hear from all of those folks. We need to engage all of those folks in our work and make sure that their concerns and priorities are addressed. The deliverables of this work stream are using any existing mechanisms to get feedback and identify gaps in our plans, and to develop some outreach plans so that we reach all of those groups. The board members that are part of this committee include Michelle Glass and Amy Fellows, who are co-chairing the committee, and then Warren George as a member. Any questions, first of all, about the objectives or the deliverables of this committee? Okay, so I'm wondering if anyone would like to propose a motion to appoint the following applicants to the Communications and Community Engagement Committee. We have, thank you. We have, and please again, forgive me for mispronouncing your name. I think it's really important to pronounce people's names correctly, and I apologize in advance. So we have Grace Hokog, Mickey Dirting, Juan Pablo Villalobos Garcia, Ellen Stackhouse, Max Brown, Jensina Hawkins, Jay Brown, John Buzzard, Craig Newton, Juana Yesenia Hernandez Solis, Katie Koenig, and Jocelyn Ogden. Is there a motion to appoint those applicants?
I move to appoint the 12 applicants to the Communications and Community Engagement Committee.
I'll second. Second by you. Any discussion? Okay, let's do a roll call vote.
Wonderful. Helen Belanca,
Yes.
Chenwei Chi,
Yes.
Debbie Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Aaron Goldberg.
Yes.
Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Excellent. Next up, we have the Finance and Revenue Committee. The objective of this committee is to design a unified financing structure for the Universal Health Plan, including creating a Universal Health Plan trust fund within the state treasury with sufficient reserves, and to study and address the impacts of the Universal Health Plan with regard to specific types of employers and households, and consider funding mechanisms within the context of the ERISA law. The deliverables of this committee are, of course, to provide financing strategy, which may include various revenue options, including income tax, payroll tax, or other options. And then an analysis of how the Universal Health Plan would impact Oregon's economy as a whole. Currently, board members include Warren George, who is serving as chair, and Cheryl Ramirez. And then I'm looking for, any questions on the objective or deliverables of this committee? Yes.
As I previously mentioned, one of the deliverables, to respond to the taxation requirement, we need to have a more accurate estimate of the cost,
Yes.
the annual cost.
Yes, and so it's a great point, and this is where there are somewhat artificial boundaries among our committees. Meaning that the plan design and expenditure committee is tasked with coming up with a benefit plan and deciding sort of what's going to be included, and we need that to figure out how much it's going to cost. And then we need the revenue expertise to know what the rate, so there will be quite a bit of intersection and overlap among the committees. But yes, figuring out the costs are going to be key to this Finance and Revenue Committee as well. We've right now housed that part in the Plan Design and Expenditure Committee, but there will be obviously some overlap. Any other questions or discussions about this committee? Yeah.
Yeah, I think it's implicit, but I think just explicitly to put it on the record. The analysis of the impact on Oregon's economy is great. I think we should add to that also the impact on individuals as well. I mean, if we're creating a revenue piece, we need to know the impact on individuals.
Absolutely.
Financial impact.
Yeah.
Any other questions or discussions on this committee? Okay, so I'm wondering if there is a motion to,
We need the names.
right, to propose, let's give them the next slide.
Oh. There we go.
I'm wondering if there's a motion to
Next, I have
appoint
a
the,
question.
yes, Courtney.
Just noticing that, Lauren was the chair for that, so we'll have to route that into the process also, or.
Yes, so the Finance Committee is scheduled to have their first meeting in October, and Warren will certainly be there and chair that meeting, and then we're having some discussions about transitioning it. Currently, the board policy state that it has to be a board member that chairs each of the committees, and so we're discussing that. So I would invite if any other board members would like to participate in the Finance Committee. Sharon, you raise your hand to volunteer.
No, I've agreed to chair. after
Oh, you have?
she leaves. Yes, I just
Okay.
wanted to let you know.
Great, thank you. So I wasn't, I didn't
Thanks.
catch that, Cheryl. Thank you. So Cheryl, the other board member on the committee, has agreed to chair. Thank you very much. Okay, so that's all that will work. We did also request that to have 2 board members on every committee if possible. That's not a requirement, but it was our goal to have 2 board members on every committee. So there still is room if there are any other board members who want to serve on that committee, that would be appreciated. Okay, so now I'm looking for, I'm wondering if the board wants to make a motion to appoint the following 7 applicants to.
I would like to make the motion to appoint the following 7 applicants.
I'm gonna just read their names so that we have them in case folks are just listening in. So we have Samantha DuPont, John Santa, Richard Gibson, Charlie Swanson, Bethany Stairs, Jeff Goodman, and Chris Hogan. And Warren has made the motion to approve those.
Second it.
Cheryl has seconded. Any discussion? Okay, so roll call.
Okay, Helen Balonga,
Yes.
Chenwei Chi.
Yes.
Debbie Diaz. Yes. Amy Fellows.
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Goldberg,
Yes.
Judy Richardson.
Yes.
And Cheryl Ramirez.
Yes.
Thank you.
Great. Moving on. We're doing that time. Here you go. Good, okay. So next is the Plan Design and Expenditure Committee. The objective of this committee is to review any needed changes from the task force recommendations regarding eligibility for the universal health plan, the benefit package that'll be included, the design of the provider reimbursement plan, as well as quality issues and cost containment issues within the plan. And the deliverables will be final recommendations on those eligibility requirements, the benefits, how providers will be reimbursed, and quality and cost containment strategies. This will include some financial modeling and actuarial analysis of various options for the plan, including expenditures. And as Chunwei pointed out, a back and forth with our finance committee on revenue possibilities and how they relate to expenditures of the plan and current costs. Currently, the board members include Debbie Diaz as the chair, me, Cheryl Ramirez, and Chunwei Chi. Any questions or discussions about this committee? Okay, great. So I'm looking for a motion to appoint the following 18 applicants to the Plan Design and Expenditure Committee. Rosemary Hemmings, Angela Michalik, Antonio German, Betsy Boyd Flynn, Brian Frank, Christine Zintner, Eve Gray, Gabriel Andine, Tashreef Rahman, Jim McGee, Jamie Osborne, Juliana Horner, Max Kaiser, Melissa Brewster, Mike Durbin, Peter Addy, Peter Merritt, and Robert Bissett. Is there a motion? The motion.
Second.
Great. Any discussion?
Okay, taking to roll call. Helen Belanca.
Yes.
Chunwei Chi.
Yes.
Debbie Diaz.
Yes.
Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass.
Yes.
Goldberg.
Yes.
Judy Richardson.
Yes.
And Cheryl Ramirez.
Yes.
Excellent. And finally, we have our operations committee. The objective of the operations committee is to design the universal health plan administrative structure based on recommendations from plan design as well as those approved by the board, to identify the statutory authority and IT infrastructure needed for plan operations, and identify potential interim strategies and or legislation needed for transition. So this is still in there, and I think we are pulling that out or separate. Yeah, so the transition work will be done by separate committees, so that's not going to be included in there.
When not yet established or when?
Right, the transition committee is not yet, has not been established yet. We anticipate that will be a little later in the process. It's also to engage with the governor's office and various agencies, including the Oregon Health Authority and the federal authorities, to ascertain and describe the necessary waivers needed for the plan. So the deliverables focus on recommendations on the administrative structure, the statutory authority and IT needs, a plan to create a trust fund within the state treasury and set up a public corporation to run the universal health plan, determine startup costs and sources of funding, and identify federal waivers needed to implement the plan, as well as a guidance to get those waivers. The current board members are Bruce Goldberg, who's serving as chair, Judy Richardson, and Warren George. Is there any questions or discussion about this committee? Okay, great. And next slide, I'm wondering if the board would like to make a motion to appoint the following 10 applicants to the operations committee: Anne Lovejoy, Douglas Flo, Laura Byerly, Paul Stanfill, Rosalind Lindsay, Michael Horry, Doris Karangu, Sarah, I'm so sorry, Paula Weldon, and Lori Hoagland.
And Chair, I'll move to approve the members as presented.
Second.
Any discussion? Okay, and roll call.
Helen Belanca.
Yes.
Chunwei Chi.
Yes.
Debbie Diaz.
Yes.
Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass.
Yes.
Chris Goldberg,
Yes.
Judy Richardson,
In gratitude, yes.
and Cheryl Ramirez.
Yes.
Great, excellent. Welcome to all of our new committee members. We are so glad to have you on board. We look forward to, and we look forward to launching our first couple meetings in October and then the second set in November. So now is a good time for a break. It's just 10 o'clock. Yes, did you need something?
May I make a suggestion?
Yes.
We're a little ahead of schedule, and I know that, there were some time constraints for the cost growth target presentation, so that wouldn't be until 10:30. We propose moving the status report or some other agenda item up to, so that we can keep that, presentation at the same time?
Yes, so should you break now and then do the status report after break, or do that first and then break?
What's that? That's up to you guys, I think. I'm happy to do the status report.
Now, I'd say do it now.
Do it as status report now. Okay, all right, let's do the status report now, and then that shouldn't take. So we have that as 30 minutes. Is that okay?
It'll be less than that, but then we'll be closer to the break time.
Okay, let's do the status report and then we'll break after that.
Great. Thank you. So just a reminder, at the last board meeting, we talked about a process for developing the status report to the legislature. The status report is an update on the activities of the board that is due to the interim committees on health by December 1st of this year. It's a annual status report, so we'll have one next year as well, to give updates on the progress before the comprehensive plan is due in September of 26. So the process that I proposed and you all agreed with was to that I would come up with an outline of what should be in the status report for you to review and give suggestions and see if anything's missing or anything that you'd like to add. And then staff will take that back and we'll kind of fill out the outline and bring back a draft report for you to review in October. And then we will come back and we will take feedback in October, and then we will come back in November for the final approval of that report prior to the December 1st deadline. So in your materials and on the website is a draft outline talking, it's kind of divided up into past, present, and future. So just at a very high level, you can all read the outline, but to talk about the important past of the Joint Task Force and the Senate bill, but to give context for the work of the board. Talk a little bit about getting started, some of the timeline between when the legislature passed Senate Bill 1089 and the board having its first meeting was getting staff approval, getting the executive director hired, getting the folks, Jenny and Katie hired here. Then setting the foundation for the board, giving the board the information, setting the foundation and presentations to the board, and some of that work group work that you all did and reviewing and updating the values and principles. In talking with Helen and Warren, we wanted to make sure that we called out the public, the engagement with the public and the public transparency work that has happened, including the outreach and community recruitment, and in those work groups, and making sure the discussions of the board are happening in public, and then really kind of looking forward with that work plan, talking about the work streams and the work committees, and some of the committees will just be getting started by the time we're submitting this. So really, then we wanted to talk about the future and include, each committee will have a work plan and make sure that we're sharing the plan for accomplishing all of the work in those different work streams. And then, of course, just a couple of other pieces. That's the overview of the status report. That will be accompanied by a letter from the chair and the vice chair, and then we'll have any supporting materials that will be helpful for the legislative audience to understand the work. So is there anything missing from this outline or anything that you think at this point we should really be emphasizing in this status report?
Yeah, no, the outline sounds great. I guess I would just say, just honestly, we haven't done a lot yet. So I think, putting that aside, I think the importance of the report would be, and since people only read the first couple of pages, is to lay out, one, a compelling reason and vision for the task force, and two, focus on the values work, which was done as well. I think you can't repeat that enough. And that really creates the foundation for the future work. So to me, you know, 1 or 2 pages of that in an executive summary, in the beginning of the report, and in the letter from the chair and co-chair, I just think would be really compelling. You know, a lot of the rest of it, you know, well, yes, we've established committees and all of that, but that to me, that should really be the meat. It should be short, it should be compelling, and it should be sort of the mantra that we continue to talk about as a board as we move forward.
Great, that's really helpful. Thanks. I wonder too, given like sort of our earlier discussion today, if we should also include something about our anticipated needs, you know, a little bit about the budget and resources, but
Yeah.
kind of what we think we might need to get this work done and outline that as clearly as we can, what we know. Put that in.
Mhm.
Anything else?
Michelle has her hand up.
Oh, Michelle, yes.
Thank you. This is Michelle, and to add to my colleagues' comments, I think I wonder if there's an opportunity to not just name specific needs to the degree that we know them right now, but also just to really emphasize the need for ongoing active support and partnership from the legislature, both financially, but also perhaps in other ways, engagement, and emphasize the fact that this work is resource intensive and time intensive, and that we're going to really depend on ongoing active support from the legislature and ongoing resource investments for this to be successful. This isn't something that SB 1089 established and gave us everything that we need, because it's such a dynamic process of engagement with Oregonians and of discovery of you know, what's going to be needed, study and discovery. I think that there could be a sense from legislators in a report that you know, that we might, an assumption, it could be easy to make an assumption that we are good and we're gonna just do all the work. But I think emphasizing the partnership and the iterative relationship between this board, communities across Oregon, and the legislature to really get this done. It seems like an opportunity to not just make specific asks, but to make this kind of broader ask for ongoing engagement and partnership.
That's great. Thank you, Michelle. And also thoughts or comments on? Okay.
I'm seeing a lot of heads nod. I really like that feedback and the way to structure and what to emphasize as we think about actually drafting this. So that's great feedback, and we will bring back, oh, sorry.
No, I just want to know, are you presenting this or are you just submitting it to the legislative? I'm just curious.
Yeah, the requirements in Senate Bill 1089 are that it's submitted to the interim committees, and then we'll work with the committee chairs to try and give a presentation during the December Ledge Day. So it's due before that, and then we will work to make a presentation as well.
Yeah, I'll speak personally, my goal is to accompany it with a presentation. I think that really helps. We have worked so our Senator Manning and Rep. Nelson are the chief sponsors, and we are reaching out to them to talk to them about the work and make sure that they're updated, of course, because they were co-sponsors of the bill. but then Rep. Nose and Senator Patterson are the chairs of the respective healthcare committees, and we'll be talking to them directly and making sure that they're aware of the work. I've spoken to both of them myself already, so yeah, so we want to keep in close contact with all four of those folks, and as well as the governor's office, and make sure that they're aware of our work on an ongoing basis, not just with these yearly reports.
So then just to follow up, we may want to look at the slides too. To Bruce's point, let's put the most interesting information at the front. And I've done enough legislative presentations that make it really snappy.
Yeah, yeah. Yeah, the slides that we send out after the meetings are intended for sort of the more involved conversations that folks want to have with community groups, advocacy groups, interested parties in the public, kind of orient them to our work and kind of track what's going on. But I agree with you, if we're gonna, I don't even know that we would have this slides, but yeah, but yes, we would make a, yeah, something compelling and fast, yes. Yes, Michelle, oh, Michelle.
This may already be the plan, but just to ask that the board members and also folks who have signed up for updates from the Universal Health Plan Governance Board be notified ahead of that meeting so that we can all tune in and in support when those presentations are made. I would appreciate that.
Absolutely, we can definitely do that.
Other thoughts, comments, discussion? Okay, let's take a break. It is about 10:10. We can reconvene at 10:20. That works? Is it? Am I clock off?
Yeah, you're good.
Yeah, it's about, yeah, so it's about 10:20, but we can reconvene at 10:20. Yes, okay. Let's reconvene.
Good to go.
Welcome back, everyone. We are going to be reconvening. Are our presenters available?
Yes, they are available.
Okay, great. Then we will move ahead with our next agenda item, which is a presentation on the cost growth target program. And we have Sarah Barnum. Welcome, Sarah, and I'll hand the mic over to you.
Hi, thanks. Good morning, everyone. I'm Sarah Bartleman, she, her pronouns. I'm with the Oregon Health Authority and I manage the Cost Growth Target Program. And I'm joined by my colleague Trang Wedemeyer. Trang, are you here and want to introduce yourself?
Hi, everybody. I'm Trang Wedemeyer. I'm the policy lead for the Cost Growth Target Program, she, her pronouns.
So Trang and I are going to co-present about the Healthcare Cost Growth Target Program. Next slide. We are going to give you a really high overview of what this is, why we have a cost growth target in Oregon, who it applies to, how it works, what the process is, and how are we doing. We're going to probably cover a lot of information. I'm happy to take questions as we go, or however you'd like to handle that in the room proper. But I'm going to just dive right in with the background. So I'm sure that the board is well aware that healthcare costs are growing. This chart is showing the annual increase in national. Sorry, was there a question in the room? Okay. This chart is showing the annual increase in national healthcare spending. So this is a measure that CMS uses to look at healthcare spending. It is a very broad measure, and you can see that healthcare costs have been growing steadily every year. This is year-over-year change. That spike in 2020 reflects all of the investment that was made in terms of things like provider stabilization payments during the first part of the COVID-19 pandemic. So a little bit higher than usual in 2020. Next slide. The CMS Office of the Actuary also not only calculates what the cost growth is, but projects what cost growth will look like for the next decade. Every year they update that. And so the most current update that we have nationally, healthcare cost growth is projected to grow 4.8% per year between 2022 and 2031. So the dashed line on this graph here is that projected growth. And you might have also seen there's been a lot of media in the last 6 weeks or so with various consulting firms, experts, employer groups that are projecting healthcare cost growth in the short term. And we're expecting, anywhere I've seen estimates that range from 6 to, double digits cost growth just in the next year. So we are expecting some higher growth immediately, but long-term, next 10 years, about 4.8%. Next slide. So we focus on a cost growth target program because making small differences in spending can really add up. We expect that healthcare cost growth will continue to grow year over year. We're not saying that we expect it to suddenly stop or trend the other direction. That's sort of not reasonable given the way the current system in this country is built. But those small differences really add up. So if we look at what the projected growth is, that 4.8, 4-ish% growth year over year for the next decade, starting at about 13,000 per person, healthcare cost growth would grow to about 20,000 per person in 2031 using this specific federal measure. If it grew 1% more than projected, that would be 22,000 per person. And if it grew 1% less than projected, that would be 18,000 per person. So really a lot of what we do in this work is think about that cumulative growth, that effort that the cumulative changes and those small changes compound over time. And so what we're really looking at, and you've probably heard this because it's been a hot topic in health policy for a long time, the sort of bending the cost curve. We really want to get it a little bit lower or maintain it or contain it to that slower growth rather than just unrestrained. Next slide. How did we get here? You've probably seen a lot of these slides. We've been talking about this for a long time in Oregon. This is a compilation of some earlier data points from some of our 2016 and 17 conversations. US healthcare costs are twice the average in other countries. Specifically, cost growth in the private sector is putting a ton of burden on people. For a while, Oregon had some of the highest spending growth in the country. We were growing faster than many other states. That slowed down. We're now a little bit more in the middle, in the average of middle of the pack. And we know that that spending is primarily due to high prices as opposed to utilization. These are old slides. I've used these slides a lot, but this is still the story. The Commonwealth Fund just released a report this morning. I don't know if people have seen it. It's called Mirror Mirror, and it compares the US healthcare system to 9 other countries. And this is still the case. We are spending more with worse outcomes. And I can replace this slide with a bunch of updated charts, but the overall message is still the same. Next slide. And then in terms of just the impact, bringing it back a little bit more locally from that national perspective, we know that this cost growth really burdens people in Oregon. Some survey data from 2021 says that 1/3 of Oregon adults reported delaying or foregoing care due to costs. The most common type of care that people report skipping or delaying or foregoing is dental care, which might make sense. Fewer people have dental coverage than other types of health coverage, but that is the number one thing that people delay. We also know there's delays in care, whether that's avoiding or pushing out appointments longer, skipping recommended medical tests or treatments. And then we know pharmacy costs are also a real burden. And we hear, 1/4 of Oregon adults reported that they were cutting pills in half, skipping doses, or not filling prescriptions because of cost. This data is from 2021. We have some new data from 2023 and 2024 coming soon, and it tells a very similar story. This cost burden continues to affect people in Oregon. Next slide. And we also know that there are disparities. We know that there are racial and ethnic differences and rural and urban differences, sort of whichever way you slice it, we can find some disparities in the data. So what we're looking at here is people in Oregon reporting that they were unable to pay medical bills by race and ethnicity. And we see that there's quite a range in terms of problems paying over the past 12 months. About 1% of Asian people in Oregon reporting problems, all the way up to 14% of Middle Eastern or North African people in Oregon. So this measure, whichever measure you look at, we can find some similar disparities by group. And this is sort of short-term and long-term medical debt over time. There was also some news that came out this morning. I was just reading the Portland Business Journal article about the percent of people in Oregon with medical debt. We are one of the states, we're on the low end of people with medical debt. About 4.8, I think was the number of people in Oregon have medical debt. We're the 6th lowest state in terms of medical debt, partly because we've done so much work in expanding coverage to so many people so that they don't have that burden of being uninsured and their cost impact. But despite that, we have a low rate of medical debt. We have a lot of protections and coverage, and yet people are still experiencing these cost burdens. People are still skipping care, delaying care, and we know that there are disparities in how that is impacting the Oregon population. Next slide. So, like I said, we've been having this conversation in Oregon for a long time, and containing the growing healthcare costs and addressing this affordability burden has been an Oregon priority. Way back in 2017, there was a joint legislative task force that some of you may have participated in. That task force was originally charged with considering a hospital rate setting model. So really specifically charged with looking at hospital prices, hospital contribution to cost growth and affordability overall. There was a model in Maryland that the legislative task force studied and assessed whether or not that would be a good model for Oregon. And at the time, for a variety of reasons, that was not the recommendation. And the task force said, hey, Massachusetts has this really cool new program, a cost growth benchmark program. That's the right fit for Oregon. So the legislative task force recommended pursuing a cost growth target approach. That led to legislation in 2019 that created the program, stood up an implementation committee, and really led to building it all out. Next slide. This cost growth target approach, it started in Massachusetts. We were the 4th or the 5th state to adopt it, but it's been growing since 2019. 9 states are now using a cost growth target approach to address healthcare affordability, and several others are considering it. So this map shows the current states. I want to just talk briefly. Nevada used to have a cost growth target program. It was an executive order through their governor, and when their administration changed, they have stopped that program. So they were one of the states, and they have stopped focusing on that in the present. And then also calling out Utah. Utah has a public-private partnership, sort of a voluntary collaborative cost growth target program that has been stood up recently. So calling them out because they're not in statute or an executive order, but they are also doing a cost growth target program. And again, other states continue to be interested in this. One of my favorite statistics now is with the addition of California, 1 in 5 people in the country are covered by a cost growth target program. All right, so that was a lot of background. Trang's going to tell you what the cost growth target actually is.
All right, thanks, Sarah. Let's go to the next slide. So what is a cost growth target? It's pretty much what it sounds like. It's a target we have as an entire state that says that total healthcare spending should not grow more than 3.4% per year. So as Sarah said, this is, yes, understanding there is positive growth, but trying to keep the steepness of that slope, not so steep, a little bit flatter. Let's go to the next slide. So we do this by having a target for everybody, bringing everybody to the table, state, payers, provider organizations, to ensure we have this sustainable rate of growth. So in a cost growth target program, we have these 4 main domains we operate under. Transparency in healthcare spending, that target everybody can aim for. Viewing total healthcare spending under a total cost of care approach, and having a common goal, which we mentioned before. Let's go to the next slide. So the program is designed to operate on this annual cycle. As you can see, it all starts with measuring the data. This is something we've been doing it since the fall of 2021. And we've been rolling out all of these activities in the following year since 2021. This program was designed to have a pretty long runway with analysis, publishing, accountability. So you can see all of those activities on the wheel. The idea is that we measure healthcare spending, we report out on it publicly, we have a public venue, a public hearing to talk about what the trends are, and we have space and opportunity for people, actors in the whole healthcare system, to try to figure out what we can do about it, identify opportunities, strategies to slow that cost growth. Let's go to the next slide. All right, so who does it apply to? I already kind of mentioned who the players were. Next slide. Okay, thank you. So the cost growth target applies at 4 levels. We report it at the statewide level. We will report it at the market level, Medicare, Medicaid, and commercial. And then probably very importantly, we report it at the payer level and the provider entity level. We always make sure to group like versus like. Each of those 3 markets can be pretty different. The characteristics are pretty different. So when we view one market, it's payers in that market, it's provider entities in that market. And for payers, to collect data from them, we require them to be of a certain size. This is at least 1,000 covered lives in Oregon. For providers to be included in the program, they have to have at least 10,000 attributed patients across all markets or 5,000 in a market. Accountability will operate a little bit differently. This is just to be included in the program for data collection and reporting. Next slide. Go into that a bit. All right, so the most current data cycle we have from 2023 covers spending for 2021 to 2022. So just to give you an idea of how big these groups are in that data cycle, we had 30 payers that are included for cost growth target reporting. You could see them broken out by their market. Keep in mind that some payers may be present in more than one market if they cross that minimum size threshold for us. So with public reporting, we do require that payers have at least 5,000 covered lives in a market to be reported. And next slide. For provider organizations, It's the same threshold, at least 5,000 attributed patients in any one market. In the last data cycle, there were 52 provider entities that were large enough to be reported, and you can see the breakdown in that figure on this slide. Next slide.
Frank,
Oh,
sorry,
yeah.
I want to jump in real quick. An important point that we have here for provider organizations. We are not measuring individual providers. We are not talking about any individual clinician or small organizations. We really roll this all the way up to the sort of the parent level. So for example, we measure Providence, the health system, Kaiser or Legacy, the system, and that includes all of their medical groups and associated practices under that. We're not measuring the individual clinics or individual facility locations. So 52 provider organizations statewide sounds like a lot, and it is a lot compared to other states. I believe Massachusetts reports on 11 provider organizations compared to our 52. So we have a pretty broad inclusion criteria. The cost growth target statute says measure all payers and providers in Oregon, but we really want to keep that focus on sort of that parent organization who is making decisions or implementing policies that can affect cost growth. And so we focus on that parent organization level.
All right. And actually, Sarah, this is you.
I'm going to keep going. Okay, so I'm going to unpack a little bit more about the program process itself. So every year, per that annual cycle that Trang shared, we measure cost growth relative to the cost growth target. We do a lot of analysis to identify what the cost growth drivers are. So why were we over the target? And is that different in a given market? Are the reasons for cost growth in Medicaid different than the reasons in the commercial market? Short answer, yes, usually. We look at where there's variation in each of those groups. Is there a difference by payer? Some payers are meeting the target, some are not. Why? What are they doing differently? So we do a lot of analysis and unpacking of all of that. We then have a very clunkily named determining reasonableness process, where for any payer or provider organization that has exceeded the target with statistical confidence, which I'll talk about in a minute, we then have a conversation about whether or not it was for a good reason, an acceptable reason. And because there are acceptable reasons for cost growth, as a state, we have prioritized things like investing in primary care and behavioral health. If we see that payers and providers are making investments in population health or improving health equity, that's good. We want to see that spending increase. And so this is more of a right sizing necessarily than just an automatic all cost growth, all spending increases are bad. So then after that determination, then there's public reporting and other accountability that I will talk about in a second. Next slide. So the cost growth target program does have accountability. We are not just a measurement and reporting program, although that is a key function of the work. Transparency, creating those public reports, holding that public hearing, that public forum for discussion, all of that is really important. And Oregon's program also has teeth, especially relative to some of our other states that do not. So in the future, and I'll show the timeline in a second, but for payers and provider organizations who exceed the target with statistical confidence and without a good reason, so all of those criteria need to be met, they may be subject to a performance improvement plan. And then in the future, if they continue to exceed the cost growth target year over year without a good reason, they may be subject to financial penalties. We just completed some rulemaking in July that codified the reasons, what's an acceptable reason for cost growth, how the performance improvement plan process will work, and how the financial penalties will be calculated. Next slide. So this is the list of acceptable reasons for cost growth. As I said, codified in statute. This has been directed. We've been talking about these reasons for a long time, since that 2019 legislation, since the original implementation committee discussed and recommended how the program should operate, because there are factors that can drive cost growth that are not within the control of any individual payer or provider, and we don't want to be penalizing any organization for that. So for example, in addition to the other examples I already gave, let's say the state mandates coverage of a new benefit and says all insurers must cover this really important preventive service or this really exciting new treatment. That will increase costs for payers because they are now required by law to provide that service. So we don't want to create a situation where we're then penalizing a payer for being in compliance with another law. So that is an acceptable reason. We also borrowed some insurance terminology here, acts of God, sort of natural disasters, pandemics, unanticipated factors that could affect cost. We also have things like new pharmaceuticals or treatments entering the market. One of the classic examples, classic, it's not that old. A few years ago, there were new treatments that came out for Hep C. They were incredibly expensive, and we can see a really sharp spike in the data as those treatments were made available to people. That's a great reason. Those are life-saving, life-changing treatments. We don't want to be creating a system where any payers or providers are disincentivized from providing those services. So again, we go through that process to discuss with each individual payer or provider organization why they exceeded the cost growth target and how that compares to this list of reasons. Next. So Trang mentioned that we had a long timeline. So this slide shows the timeline in a little bit more detail. So we've been collecting data and reporting on it for 4 years now. We started publicly reporting on payer and provider cost growth 2 years ago. And we are in our 4th year of data collection and submission right now. So the little "we are here." Data was due 2 weeks ago for this current data cycle. We'll be publishing our next annual report, likely spring 2025. And those accountability measures, the bottom 2 rows of this chart, show the phase-in of accountability. So performance improvement plans do not apply until next year, potentially as the first time. And then financial penalties do not apply until even later than that in that timeline. Again, this was very deliberate. There was a lot of conversation about how quickly can the health system, payers and provider contract negotiations, how quickly can those changes be made? Contracts are often multi-year. They're negotiated prices or agreements or payment agreements for several years in a row. And so expecting some of these changes to be fast or to happen in a 12-month cycle was not realistic. So we wanted to make sure that there was a really long on-ramp. Everyone knew what the target was. Trang didn't say this, but adding the cost growth target in Oregon, we set it for 10 years. And we've said this is what the target will be for the next 10 years so that entities have that predictability, the stability. They know what to be aiming for. They have that common goal. Okay, a couple more technical details. I'm going to explain what we're actually measuring in the cost growth target. So we use 2 measures. On the left, total healthcare expenditures, or THCE, and on the right, total medical expenditures, TME. TME is a subset of the total healthcare expenditures. So the total healthcare expenditures measures all claims payments, non-claims payments, net cost of private health insurance, which basically is administrative cost of the payer, and other spending. And that's other spending that's happening in the state. So that's things like how much are we spending at the Veterans Affairs facilities? How much are we spending on healthcare at the Department of Corrections? How much are we spending on behavioral health contract to county mental health providers? So there's a lot of other spending that's not necessarily a negotiated payer-provider contract, and we capture all of that in the total healthcare expenditures measure. Between 21 and 2022, total healthcare expenditure spending grew 3.6%, so just above our cost growth target of 3.4%. Total medical expenditures is just the claims and non-claims spending, or more narrowly, just the payments flowing between a payer and a provider. So what could be negotiated? And that spending in 21-22 grew 1.5%. You might be thinking, why was that lower? One of the reasons in this time period is we were still seeing some utilization rebound from COVID, and there's more spending growth, or there's more money in the admin bucket. So that net cost of private health insurance actually grew 8% between 21 and 2022, and that's partly why there's a difference between these 2 measures. Next slide. So this may be confusing, but graphically showing what we're pulling into that TME and THCE measure. So if we look at all the ways that the money flows, and this is not all the ways, this is a vastly oversimplified way that all the money flows in the health system. But if we look at where some of those dollar flows are, the light blue highlights show what's included in our measures. So we look at how much on the top right-hand side of the triangle, how much the providers are receiving from members in terms of out-of-pocket costs, how much the providers are receiving in payments from the insurer, and then again, the insurer admin costs on the bottom left. Really important to note here, what we're not measuring, which is the left top of the triangle, we are not measuring premiums. Premiums feed into this and are an underlying part of the dynamic, but they're not explicitly what we're measuring. And so one question we get a lot is, my premium went up 7%, but I thought we had a cost growth target in the state. How is that allowed? We're not measuring premiums. Premium growth is not subject to the cost growth target. Premiums are regulated by our sister agency at DCBS. There's a whole conversation about how those two things intersect, but just at a very high level, we're not measuring premiums as part of the cost growth target. Okay, so finally, I'm going to talk about how we're doing. So share just a little bit more data with you on cost growth in Oregon. So if we look at 21-22, again, our most current measurement period, total healthcare expenditures grew 3.6. The chart on the left here shows the trend. So 3.6 is actually pretty consistent. That's what we saw between 18-19, 2021, 21-22. We see a dip between 19 and 20. That is because utilization really just stopped. There was a lot less healthcare utilization because of COVID. And so we see that reflected in the overall spending. If we look at the right, we can see that that 3.6% really varies by market. Medicare spending actually grew the most in this time period, 2.2%, followed by commercial spending at 1.5% and Medicaid 1.2%. And again, the difference between that 3.6 and these market specific is because of that administrative cost and some of the other spending. We saw a lot of other spending in 21-22. Again, some of those provider stabilization payments, there was just a lot of, I don't want to say a lot of noise in the data, but there was a lot happening. Okay, let's take another look at why, or what are some of the factors driving healthcare spending. So this bubble chart is something that we've been using in our reports lately, and it shows a lot of different things all at once. So what we're looking at is by service category, statewide in Oregon, how much is spending in each category contributing to cost growth? So basically, the larger the bubble, the more that service category is contributing. So if you look left to right on the graph, that's cumulative growth. How much has spending in each category grown between 2018 and 2022? If you look top to bottom, that shows you how expensive it is per person. So we can have a dynamic where something has grown a lot, but it's a really inexpensive service. And so it's not going to have as much of an impact on something that maybe doesn't grow quite as much in terms of a percent growth, but is actually very expensive on a per member basis or per person basis. So between 18 and 2022, we saw a lot of growth in non-claims spending. So you can see that over on that far right bubble. Those are things like value-based payment arrangements, capitation, quality incentive payments, anything that's sort of not a fee-for-service payment. In this time period, there's a really big shift, especially from Medicaid and Medicare, towards prospective payment arrangements. And we saw a lot of dollars move into those types of agreements. If we look at the more claims-based traditional fee-for-service kinds of spending, retail pharmacy and hospital outpatient are the two big areas, big cost growth drivers. That's been true for years. And no matter which way we slice this, if we look by market, Medicaid, Medicare, commercial, those tend to be the biggest cost drivers. They're also the biggest cost drivers nationally. Other cost growth target states do similar analysis, and we compare, and they also are highlighting hospital spending and retail pharmacy spending. Okay, next slide. So going and looking a little bit more at the payer and provider performance. So cost growth varies a lot. There's not one clear story, even by market. So the graph on the right shows the distribution. Each dot is one of those 30 payers that we're measuring. The orange dots are commercial, the red dots are Medicare Advantage plans, and the green dots are Medicaid. So of the 30 payers that we measure, 19 met the cost growth target for at least one market. But you can see there's a spread here. We've got some green dots that met the target and some that didn't. We've got some commercial plans that met the target and some that didn't. it's not like all commercial plans are failing to meet the target and all Medicaid plans are meeting the target. It's not that clean cut. Next slide. Similarly, for provider organizations, we see a really different experience across the board. So same distribution. We see of the 52 provider organizations that we're measuring, 29 of them met the cost growth target for at least one market. But it varies. Again, you see we've got some commercial organizations on the right of this graph that have very low or negative growth, and some that have very high growth. I also feel like I have to also sort of provide a disclaimer here. This includes some pediatric organizations. We do measure pediatric organizations if they meet our other criteria. Pediatric providers tend to have pretty low spending on a per person basis. And that means that one very sick kid can drastically change their spending growth up or down in a given year. So some of these sort of high and low ends of the distribution are coming from that. And again, going back to some of those acceptable reasons for cost growth, that's not a problem. We want those kids to be able to receive the treatment. We know that's just sort of how we're measuring and how we're including it. So, you know, you might say, oh my gosh, who has 28% spending growth over there? And I just want to acknowledge that sometimes one person can really be enough to change the trend. Okay, and last couple things I'm going to share. I just want to, at a high level, share what we heard from payers and providers about the cost growth for this time period. We meet with each of those payer and provider organizations and validate their data, talk about why they exceeded the target or why they met the target, and what was going on for them. We want to have that on the ground perspective to provide context and inform this discussion. And so here's a little bit about what we heard in 2022. From the payer side, there was a lot about that post-COVID utilization coming back, people scheduling and coming back into the office. Retail pharmacy continues to be a big cost driver. We heard that there were catastrophic claims. So that's the sort of technical insurance term for a really expensive person, a really expensive set of treatments that is needed. So sort of a high cost outlier. There was an increase in people that were having those experiences. And then there was an increase statewide in behavioral health spending. And again, something that we're really happy to see more investment in. On the provider side, we heard a really similar story. And a couple of other things that we heard on the provider side were expanded services. There were some new, for example, there was a new cancer center that was opened in this time period that affected one of the providers' spending because then they were able to treat people locally at their new cancer center rather than basically sending them to Portland. We also heard a lot from our pediatric providers about the pediatric triple-demic, sort of COVID, flu, and RSV sort of all hitting at once and really affecting pediatric costs. So we sort of expand on all of this in our public reporting, and our public hearing creates a space for some more of these conversations. But at a really high level, I think maybe what I'd want you to take away from this is there's not one clear story about what's happening for cost growth in Oregon once we start digging in by market, by payer, by provider. There's a lot of factors and it's a very complex dynamic. And then last slide, finally, I just want to be very transparent about this. The cost growth target is just a number. It is a goal. We are trying to achieve it, but we have to be trying to achieve it by doing something. The cost growth target is a catalyst for those strategies or for those actions. Hopefully the accountability measures provide some incentive or disincentive for payers and providers to take action, but without anyone taking action, we're just going to be measuring and reporting on what else is happening. And then we go back to some of those national projections about what will happen potentially without any concerted efforts or actions to address cost growth. So cost growth target by itself is a tool, a framework to help understand how we're doing, to create the structure for all of this data and context. But really the goal is to identify those strategies and those opportunities and then implement them. So really, we've been focusing mostly the first couple of years of building this program on the right side of that circle. And we really want to be moving the conversation into the left side onto those strategies. Because if we're not doing anything to actually make a difference, we're just going to be documenting. So I will stop there. We have some links in the slides for more information, and I guess happy for questions or discussion.
I have a question. Sarah, thank you so much. That was a fabulous presentation and really helpful. I find it like there's got to be some really interesting discussions that go on behind the scenes. I'm particularly interested in like when cost growth is justified or not justified, that conversation. And you mentioned in there that sometimes there are new treatment options available that that warrant you know, an increase over the cost growth target. But that's got to get tricky. I mean, you gave an example of a great treatment for Hep C that really does change the scope for folks with that disease and is really worth paying for. But there are scores of new pharmaceuticals and treatments that come on the market with only marginal benefit over the standard, but a really increased price tag. So what is the mechanism for deciding, like, if this new fancy treatment, if this new fancy sort of opportunity for therapeutics, that it warrants a significant growth in costs? Like, where does that discussion happen? Who decides that?
Yeah, that's a really hard question to answer. So let me try to talk around it a little bit, because I think there's not an official decision process, and I don't want anyone to come away from this answer thinking that we have some sort of shadow health evidence review commission that's making those decisions. What we have that came out of our rulemaking in July is some additional guidance that talks about how we interpret that and what that means to us, but it's certainly not a specific treatment or procedure or drug by drug level review. I think when we approach these reasonableness conversations, they're often pretty categorical at first. And we say, all right, based on the data, it looks like all of your spending growth this year came from, let's pick an example, from hospital outpatient services. Let's talk about what was going on with hospital outpatient. So we might never have a conversation about new drugs or treatments because that's not what was actually happening with that payer or provider's spending. So I think it will be case dependent in terms of, is that the primary driver? Is that the reason that the payer or provider is bringing up in the conversation? And is that backed up by the data? If all of those things are true, then we might get into some more nuanced conversations. And to be fair, this is the first year we're doing this process. We haven't finished the reasonableness process. This is sort of live and subject to change. But I could imagine a conversation where we say, okay, let's do a little bit more analysis, maybe on the OHA side, maybe on the payer or provider side. Let's actually find out exactly how much that new drug or treatment cost. Is that really what happened? Or is that just sort of, I don't want to say the easy answer, that sounds bad, but you know, is that what you're saying happened? Or is that what really is backed up by the data? That may or may not sort of pan out. Let's say it does. I could then see a conversation where we say, okay, what was happening? Were you, did you have a discussion about this, say this new drug versus a generic or biosimilar? Did you have, was there policy or coverage guidance? Were you doing anything to attempt to mitigate the cost? What were some of your considerations? How did this factor into contract negotiation? So that's very downstream. And I think what I want to share is that this is iterative and nuanced and less of a, this drug is in, this drug is out, black and white kind of answer, where if a payer adopted a new drug on their, you know, on their formulary, then we would automatically say not a good reason. And we do have other bodies in the state that do this kind of review. So on the Medicaid side, we do have the Health Evidence Review Commission. And so I might have a question for a Medicaid plan that maybe adopted something before it was approved through the Medicaid processes and formularies. But there isn't a parallel group on the commercial side. So I'm rambling a little bit, but I think it's not a black and white decision. There is no sort of decision body. It is these iterative conversations based on the specific payer and provider data.
Thanks, Bruce. I think you.
Yeah. Hey, Sarah, Bruce Goldberg. Two quick questions. One is, how do you figure in the consumer perspective? Because, you know, gee, a premium may be 3.4% more, but if my deductible has gone from 1,000 to 2,000, that to me is 100% increase in my healthcare costs. And you can talk all you like about what the cost growth is, but at the consumer level, it's what I pay. And so I wonder so one question is, how do you figure that in? And the second question relates to this board. As you know, we're putting together a universal health plan where we would actually have a common price that's set for the state. And in doing that, I just wonder the utility of the cost growth target, if you had indicated price was the key, if ultimately we're saying, here's the price and this is the price for everybody, it would seem that that's the way to control costs. But I'd be interested in your thoughts as the relevance of the cost growth target in a universal health plan world.
Yeah, those are such meaty questions. Okay, so first one, I think the consumer affordability, the patient affordability perspective, that real life impact, that is why we have this program. So that is the driving reason that we're focusing on controlling cost growth. And it's really important to bring that perspective into the conversation, to continue to ground ourselves in that and say these decisions, whether or not you are meeting the cost growth target, can have real life impact for people. And it's not a direct line. There are absolutely scenarios, and I think we've been seeing this, where entities are meeting the cost growth target and they have premium increases, health plan benefit changes, or deductible copayment changes that are really affecting the patient. And I think some of this is an expectation alignment conversation, and that's just really challenging to do. Like, as an individual, my takeaway is not the cost growth target says that my copayment or my deductible will never increase more than 3.4%. That's not what we're trying to do. But that's a really hard sell. And if you don't feel that, as you're saying, if you're feeling the 1,000% increase, it's really hard to feel like the cost growth target is working. And one of the things that all of us states with a cost growth target program sometimes talk to ourselves about is it's really hard to message it would be worse without us. We're trying to aim for 3.4%. If we weren't trying to do that, cost growth would be unchecked. Maybe that increase would be even worse. Not from a we're trying to save the world perspective, but it is a tool, and the impact is not going to be equally felt by any given individual. And that's a really hard thing to communicate and a really hard thing to walk away from, where we could be doing great statewide in aggregate, but individuals are still hurting. And I don't really have a good answer on how to reconcile that. I think that is a factor of the program. The dynamic of the system. I think we do try in the program to focus on the consumer impact, to measure and report on affordability, to measure and report on cost sharing and how that's changing. We have a really cool cost sharing dashboard that we put out a couple months last year, recently, which if you haven't seen it, we're really trying to explore what those impacts are and how the dollars are shifting in the current system. But yeah, at the end of the day, the cost growth target is not necessarily going to have any say on whether or not someone's deductible goes up. Second question. I want to be flip and say, yeah, this conversation with the 2017 Legislative Task Force started with, shouldn't we just set prices for hospitals? And as a state, politically, stakeholder input said, that's too aggressive. If you focus too much on prices, utilization will just increase to drive costs up, the squeeze the balloon dynamic, all of that. Really, that's too top down. You need to set this common goal, take a cost growth target approach, let us all do what we need to do locally as payers and providers, regional variation across Oregon, whatever that looks like. Let us do what we need to do to meet the cost growth target, to keep costs under control. I think we are in the finding out period. We're seeing, does that work? Are payers and providers actually taking action and taking it seriously and working to meet the cost growth target? And if they're not, I think we come right back to that same conversation. Here are the cost growth drivers. You had opportunity to meet them. Did you? Is that successful? Or do we need to be talking about a different approach? And I think what you're talking about in this board with price setting or other tools, and there are a lot of other tools that states are considering, that is absolutely the conversation. That might be the conversation that states with cost growth targets get to, whether or not they're having a universal health plan conversation. At the end of the day, the cost growth target it's just a number, just measurement. And so do we need more aggressive regulation? So some things that other states are currently talking about, should we have a price growth target that's specific for hospitals? Should we have reference pricing where we're capping how much hospitals can charge? How are we addressing pharmacy costs? And there's a lot of work happening on that in Oregon as well as other states. So yes, it's a yes and. And so you're asking, you know, how does the cost growth target fit? Like, it doesn't have to. At the end of the day, maybe we're going to be replaced by something more more top down, more directive, more prescriptive, and maybe that's where this path is leading. So I don't necessarily see any of that in conflict. I see that that's just more, we let this conversation play out and we see, and some of those things might come from the legislature soon. Some of those things might come from your board and your recommendations on the development of the universal health plan. Some of it might be the national trend. I mean, there's a lot of national attention and national changes about how we pay and how we set prices. So I don't know if that helps.
Thanks, appreciate that.
Amy?
Sorry, I have a couple of questions. One kind of is a piggyback on Bruce's first question, but as somebody who pays for insurance through the marketplace and almost $700 a month with the tax discount currently, and it keeps going up every year. Is there any plan to interact with, I think it's the group in DCBS that approves the annual premiums and, you know, what insurers are allowed to charge? Like, is there any plan to to inform that process with this information?
Yeah, so I would say that we coordinate with our colleagues at DCBS regularly. We're aware of their process, they're aware of our process, we share data, we sort of share learnings regularly. I think I don't want to speak for anyone at DCBS in the rate review process about changes they might be considering. I do know that nationally, insurance commissioners, other state rate review have been considering things like affordability standards, either sort of on a voluntary approach or a statutory directive. Oregon does a lot voluntarily on this front. And so looking to mitigate, looking to push back on some of those premium increases where possible or where there's flexibility. But I don't want to speak for them about any potential changes that they might be considering.
And then my second question might be very specific, but I know that Oregon through Medicaid Oregon Health Plan spends $40 million a year on applied behavioral analysis for autistic children, some of them getting 40 hours a week, like 6-year-olds, which is something that's known to cause more mental health issues down the road. Is that lumped into the behavioral health bucket in your data?
Yes, that would likely be included in what we are measuring if that is part of the Medicaid spending, absolutely. We have not broken things down to that level of sort of procedure or treatment in the analysis. I think most of our sort of more detailed breakdown has been focused on pharmacy to date.
Cheryl?
I have a few comments and also one clarification question. First, I wanted to thank Sarah for all your work on the cost growth target. This is really interesting. And I think the data that you presented certainly will inform our plan design and expenditures and finance and revenue committee. So I appreciate that. I was not surprised to see the increase in behavioral spending. We predicted a tsunami after the pandemic, so not surprised at all. I'm very glad to see the increase because that means that people are accessing mental health and substance use disorder care. So that's good. I like Amy and Bruce have concerns about not including the cost to the consumer in the cost growth target because I believe not including the premiums, the out-of-pocket costs, the deductibles, seems like a glaring omission to me. And I'll just use my own example as a small business person with a very small group. Our premium goes up every year. It has just gone through the roof. And we're up to now a $10,000 family deductible. So basically, I mean, we provide some funding for an HSA, but we hardly ever get to the insurance actually paying for things. I mean, unless we have something like an emergency, a birth maybe, something catastrophic, really. So I just feel like that is a glaring omission. It's an important data point that we need to consider. And then I would say the pharmaceutical cost, the increase, that's a really important piece of information. And I believe our task force really didn't do a deep dive on pharmaceutical costs, and I think we need to go there, obviously, in our committees. So that's really important information to me. And then lastly, here's my question. What is included in hospital outpatient? Are these the pop-up urgent care centers, or does it include a lot of other things? I'm just trying to get a handle on what that is.
Yeah, so hospital outpatient is there's a bunch of very specific things that it means. So it is an outpatient setting. You're not admitted to the hospital, but you're being treated for a service in an outpatient setting. So it's more about the site of service, and it can include a range of treatments. So there are some surgeries that are offered on an outpatient basis. There are some things that are more like a sort of a doctor's visit, just a regular visit that would be considered outpatient. It's sort of a grouping category based on the location. Depending on their organizational structure and how they bill, some freestanding things could be considered in outpatient, some might be considered under professional services. Sorry, that's a very hand-wavy answer, but I can share documentation on the details if you're curious.
Thanks, Sarah.
And I just want to speak to two of your comments, Cheryl. I think delighted to share any more data or information that our program has looked at in terms of pharmacy, and would also really encourage you to connect with Oregon's prescription drug price transparency program for more information and to further that conversation. They're doing some fantastic work. And then finally, to your comment about the premiums and the deductibles, I mean, yes, absolutely. This is a conversation that we had with the implementation committee, we've had on an ongoing basis. And I think there's a difference between what we're including in the measurement and then not, and what we're caring about. So we are reporting and measuring on premium increases separately. There's a very technical reason for why it's not included in the cost growth target total healthcare expenditures measure by itself. And that, it's because it creates double counting because the dollars flow twice in that triangle, and we don't want to double count. But that none of that is to say that that's not important or that we don't care about understanding or, creating transparency and hopefully driving action to address some of those more direct consumer impacts.
I appreciate that point, Sarah. There's just a tremendous amount of cost shifting to the consumer right now. I can tell you just on a personal level, I did not buy a very expensive shouldn't have been an expensive medication, but there was such a copay, such a high copay. I just didn't take it. So
yeah.
It's just.
Yeah, and that's right back to the data of you're not, you're delaying care, skipping prescriptions, not prescriptions. Absolutely. Yeah. We hear that all over the state.
Okay, thanks.
Michelle, go ahead.
Thank you for this presentation, and thanks to my colleagues for these great questions for discussion. I guess my question builds on Bruce and Cheryl's questions around is there analysis within the cost growth targets program to see if one of the unintended consequences of this program, especially as it moves towards closer to the more enforcement implementation of the program, is there any measurement of whether that is creating an incentive to do more cost shifting, do things that are not measured in the program, such as premium increases, or to give again, to speak for myself and give a personal example, my premium went up quite a bit this year, and I was limited to 3 primary care visits that were covered at the copay. And after that, it applies to my deductible. So it's a reduction in access and increase in cost, both of which, from what I understand, are not captured in this enforcement of this program. And so is there any analysis about whether that's an unintended consequence of the program itself and what it's measuring and what it's not measuring?
Yes, fantastic question. Yes, so there's sort of the cost growth target and the specific metric that we measure relative to the target. And then there's everything else that we're measuring and putting into that conversation. And so we actually had a very specific conversation with our committee a few years ago to have a conversation about unintended consequences and what are things we should be looking out for? How do we measure them? How do we report on them? That committee ended up saying we should actually not even call them unintended consequences. They're negative impacts because they might have been a very deliberate choice that was made in the system that resulted in that impact. So we have a negative impacts monitoring plan. And so some of the other reports that I've talked about are part of that. So that includes our cost sharing report, where we actually do look by sort of service category, by plan, by market, where is that happening? How much are people paying on average in copays, deductibles? How is that changing? And we do see some really interesting changes where suddenly all of the co-payments shift into cost sharing. And so that might end up costing the consumer more because, if your co-payment was fixed at $10, that's nice and manageable maybe. But if you suddenly are moved to a 20% cost sharing and the underlying price continues to go up, your 20% is going to continue to be more expensive. So we do see and monitor some of those shifts. Similarly, we also are reporting, we did this a couple years ago. We're working on a refresh to look at what are the changes in price and utilization. So our prices, how much of the cost growth is coming from price, how much of the cost growth is coming from utilization, and then related sort of acuity. Are patients getting sicker? That's something we hear a lot when we talk to payers and providers. So unpacking that, is that true? Where is that happening? What are those negative impacts? So yeah, that is definitely part of the program, part of our reporting, and hopefully part of the broader conversations as we move forward with accountability when we have things like our future public hearings.
Great, thank you. And thanks for your work. I really see this program and other recent reforms as setting the table for where we start when the universal healthcare system goes into effect. And so we definitely appreciate this presentation.
Sarah, thank you for very informative presentations. And my question is trying to bring the cost growth target, this program, to the relevance of universal health plan. So I have a short but potentially complex questions. Who set the 3.4% target and what was the process? And just to give you an example, Taiwan's universal health plan has a global budget. So the legislatures set the 4% cap. But each year they negotiate what's the rate of increase for the next year. And there's a rate setting committee consists of government with the payer, single payer, the consumer, usually the union, and the providers, and then academic. So those groups set a rate setting committee to decide what will be the next year's growth. They cannot exceed 4%. And so far, it has been somewhere between 3.6 to 3.8%. So that was the example of the process used in Taiwan. And potentially, when the universal health plan is implemented, one of the options is considering global budget. So that might be potentially to transform the cost growth target, that program, into the global budget program and rate setting. So my question is, what was the process and who said that 3.4%?
Yeah, some great details there. So we had a statutorily created implementation committee that was created in that 2019 legislation. That group met in late 19 to early 2021 and developed recommendations for how the program should operate, including picking the value, setting the target at 3.4%. That was a primary function of that advisory committee. It was a pretty big committee. I want to say it had 18 members to start. It was about half health plans and provider organizations and half consumer advocates, organized labor, employer perspective. So trying to have a balanced perspective there. The cost growth target, we looked at a variety of economic indicators, and each state that has a cost growth target has had a slightly different process or slightly different economic indicator that they've pegged their target value to. A lot of the states, the first states, had done sort of inflation plus 1% or something like that. And Oregon, because of our our implementation committee's dynamic, said this economic measure, just looking at inflation, doesn't take the affordability perspective, doesn't take the patient perspective into account sufficiently. And so we brought in a number of other economic indicators related to things like household income, wage growth. We looked at historic trends in all of these economic indicators, so the past 20 years, as well as the future projected trends, and basically eyeballed it. So unlike the other states where there was a formula that spit out the cost growth target value, we looked at all of those trends, and then the committee discussed and came to that 3.4%. 3.4% is really similar to what all the other states have, but it was sort of a triangulation between the economic indicators like inflation, growth, and then income and wage growth in the state. The cost growth target value itself will be revisited in 2025. We had put a pin in and said, we've set the target for 10 years, but at the 5-year checkpoint, we're going to get a group back together. We'll revisit all those economic indicators and see if this is still the right value. Some other states change their target. They have to reset their target every year. We don't, and I actually think that's preferable because it means that payers and providers know what the target is well in advance. They have that long runway. They can negotiate contracts with the target in mind, all of those pieces. But yeah, we are going to revisit it next year. There is a possibility it could change, and I am expecting that it will be a similar, informed by multiple economic indicators and trend, but not formulaic. Did that answer all the parts of your question?
Yes, and I also have a quick comment, also following up on Bruce, Amy, and Cheryl's concern about consumer out-of-pocket payment. This is a similar issue in Taiwan. The global budget doesn't include the out-of-pocket payment. And so the Taiwanese government routinely do a survey on total out-of-pocket payment to track how much the consumer actually still have to pay under universal health care. So that potentially our governance board should pay attention. And maybe before the universal health plan, the cost growth target program might be tracking out-of-pocket payment and how does that grow to make sure we understand what are the burden from the consumer.
Yeah, so I'm wondering if we can connect with the staff and send some additional links to some of our other reports that focus more on the affordability patient impact of some of these costs. And then also slight clarification. So premiums not included in what we're measuring relative to the target, although we do track and report on it separately. Out-of-pocket spending or the patient cost share is. That is something that is included when we think about total medical expenditures. We're looking at, I'm sorry to get technical, but we're looking at the allowed amount, which is how much the payer pays the provider and how much the patient is supposed to pay the provider. So that spending is included in the measurement. And it's something that we can dig into a little bit in more detail, but just wanted to be clear that that out-of-pocket spending is not totally excluded the way premiums are.
Thank you, Sarah, for your work on this and also on the other things that you're involved in. I don't really have a question, but it's kind of a comment for us all to think about. And getting back to our concept of universal care and publicly funded, if the voters of Oregon accept a certain tax rate, that is accept a certain tax rate, which we all agree to fund healthcare, then we're now in a new situation where healthcare is tied to the income of the state and to the employment in the state. And so we have to come up with ways to where, I mean, we're unlikely to vote every year. We want to move from a 16% tax to an 18% tax. So I'm just throwing numbers out there. We actually have to, the voters are likely to want to stick to a particular tax rate that will be tied to our income. And we will have these challenges of how to, you know, if you want a new treatment, you have to figure out a way to make an older one less expensive. Or, these will be challenges that we'll face as we get further into our work. I don't know if you have a comment on that, Sarah.
Yeah, can I make a comment sort of related to a couple of the things that you've said so far about sort of that global budget component? And, you know, Oregon had and has a cost growth target essentially for Medicaid. We have the global budget approach for the Medicaid coordinated care organizations, and that is statutorily limited. We have basically a cost growth target baked into the global budget. The global budget cannot increase more than a certain percent every year. We had that in place before the cost growth target program was established and sort of spread that model to the full market. And so I'm editorializing, and I apologize if I'm overstepping a little bit, but depending on sort of your decisions and your design factors, if you're saying it's a global budget for the entire state, you know, it's not incompatible to say that there's a baked in, you know, the global budget will not grow more than X percent a year. So then the individual cost growth target with sort of the levels of detail of measurement that Trang and I described, yeah, that goes away because you bake it in at that global budget level. But it might be worth this group, if you're interested and if you haven't already covered it, going back and looking at some of those original Medicaid design decisions that baked a growth target into the global budget, because that might be more relevant to what you're considering.
Thank you. We have a couple of minutes and I was hoping to, we have a couple of minutes left and I was hoping to turn Bruce's question to Sarah, to this whole board. In the sense of, what does the board think of, in terms of the presentation that we've heard today? What do you all think is the relevance of this work to our plans for universal health plan? How should we incorporate what the cost growth target program has learned into the work that we're doing?
I mean, just briefly, I mean, I think putting the cost growth target work aside, let's just talk about costs. I think that if we're gonna create a plan, it's gotta take into consideration costs. And we pay a lot for healthcare that is ineffective and wasteful. And it's gonna be, I think, incumbent upon us to create a plan that actually does take into account costs. Otherwise, we bankrupt the citizens of Oregon.
I was super interested in the factor of utilization. Because if we were to create a simplified administrative structure, a single payer type health plan, certainly we'd have a lot of savings in administrative costs. What's that? One-time savings, right. And then, it's normal and expected that utilization will increase, partly because we will be covering about 200,000 more people than we currently cover. Those are the currently uninsured folks in Oregon. But also because, when people don't have such steep out-of-pocket costs, they will now access all of those services that they haven't been accessing and that they certainly, need. In most cases. So, the data that we saw, about 30%-ish of Oregonians are delaying needed care. So we have, increased coverage, we have people finally getting the services that they actually need to have. But there will also be excess utilization, right, likely, because if people don't have, one of the things that out-of-pocket costs do is they limit people from getting care that's not needed, but just, if you've had a week of knee pain, you don't need an MRI necessarily, right? But people will want an MRI, and if they have no out-of-pocket costs, some inappropriate utilization may also go up. And so one of the things that struck me about the presentation is thinking about utilization targets, which are super hard because it's hard to know when care is needed or not needed, or services are needed or not needed. But utilization and discussing, going more in depth on that. Also the shifts of, what you were talking about hospital outpatient work with where a procedure is performed determines greatly its cost, right? And if you do a certain surgery in an ambulatory care center versus in a hospital setting, you get facility fees that are very, very different. Exact same procedure costs many times higher in certain settings. So thinking about those kinds of excess costs. That's the kind of thing that comes to mind, but how we think about utilization in a single payer plan, I think is gonna become very, very relevant because utilization is gonna change quite a bit, and of course, that'll drive costs. It's hard to estimate. Yeah, Judy.
I just want to express appreciation and gratitude for the presentation and the comments so far. And Chair Blanca talks about moral hazard, and there are economic tools to address that, and they have in other states. And so learning from the work that has been done already in this program to inform our future work, I think is incredibly helpful. And to be mindful of the data that you have gathered with primary cost drivers and how those may change based on things that happen in the state. Seems a bit of a polemic to be mindful that we can iterate. We're not designing something for this moment in time to be instrumented forever. It needs to be responsive to purchasers of healthcare and things that happen in the state and how cost drivers change. And it's helpful to be able to, walk and chew gum at the same time and look at those micro drivers, but also look at the whole system. Thank you.
Yeah, already.
Chair Belanca's question, comment on utilization made me think about if there's a way to access data on at the different points that Oregon's done Medicaid expansion, how utilization has changed from people being uninsured to now having OHP. That might give us some kind of indicators.
Great. And generally, I wanted to ask you too, like what your experience has been in Taiwan in terms of, first of all, what do you think of the fact that they don't limit? I mean, so part of our plan would be to eliminate out-of-pocket costs altogether and to say that that wouldn't be part of our plan. That's in our preliminary structure, that people wouldn't have out-of-pocket costs. But you were saying in Taiwan, even though they have a global budget, there still can be out-of-pocket costs that people are charged. Like, what are your thoughts on that, or limiting utilization? What's happened in your experience?
Well, the issue of problem in Taiwan with significant out-of-pocket payment is for the government who administer the universal health plan, their incentive is to keep the budget low.
Yeah.
But then potentially there's a shifting
Yeah.
of the cost to the consumer. And that's why there's academic, but also part of the government, they're tracking the out-of-pocket payment, which presumably if we implemented universal health plan in Oregon without out-of-pocket, there will still be out-of-pocket in the sense of total health expenditure, meaning those services not covered, they're still out-of-pocket. And we still need to track how that grows. Because potentially, let's say if we have a global budget, and then the hospital, the providers, their payment are fixed, there's always a way to shift the treatment to the non-covered services. That meaning force people to pay out of pocket, but then out of the system. And that's the part we need to track. That once we implement that, we need to track how the out-of-pocket payment continue to grow. By the way, when we do the accounting, I highly recommend we follow the international WHO established and World Bank established standard national health accounting. So it's standardized what considered out-of-pocket, it's standardized what is private insurance, etc., etc. And that makes the accounting very clear and comparable. And one suggestion I have is for the board is concerning the cost inflation, which potentially will feed back to put pressure on the board and on the legislature to increase the tax, and which will form a vicious cycle. And therefore, I think the responsibility will lies in the board once we implement that, is to implement multiple cost control measures. For example, technology assessment. We need to continuous do technology assessment on the new technology, including drugs versus old, and the cost benefit on those. And likewise, particularly for drug reference price, many countries, including Taiwan, Germany, many countries are using that reference price. And negotiate the discount that Oregon as a state negotiate, because we are the ultimate payer for the prescription drugs. So the board or the governing body should have the capability to negotiate the bulk discount, which the 2003 legislation prevented Medicare from doing that. So Medicare ends up paying the highest price, but we should avoid that. So this is just some example of there are multiple cost control measure and mechanism we should consider once we have that in place. Because it's important to provide universal health care at the same time it's affordable. But if we don't implement those cost control measures, it will become less and less affordable.
Totally agree.
I just have a quick question for Sarah. Can you send that article? I think you called it Mirror Mirror. I'd like to see that. Thank you.
Yeah, we're creating a whole package of things to send you.
Oh, great. Okay, thank
That's
you.
a repeating series too, right? I have a couple of mirror articles in my folder already, right? They do that frequently. Any other thoughts, questions, comments? Sarah, thank you so much again for coming, and thank you to Trang as well. We really appreciate you being here and being part of our discussion. It's been incredibly helpful, so thank you.
Thanks for having us.
Okay, so we have some public comments that I want to get to, but first we do this little section at the end of our meeting to talk about meeting takeaways. The purpose of this is to add some key talking points to our documents that we give to all of you as you go out and speak to your communities, interested parties, advocacy groups, and to update our PowerPoint. So we want some agreement from the board on what the key takeaways of the meetings are. I'll get us started and just say, I think our key meeting takeaways are Warren's departure and the need for us to replace our vice chair and our finance committee chair, which we've done. Sorry, I did not do that in my notes. The launch of our new committees, of course, with our new members, and our discussion on cost growth and how it applies to our plan. And then finally, that we're pretty well positioned for our first report to the legislature. Any other key meeting takeaways that you want to have included in those materials?
Cost control is going to be important.
Yes.
Reach out to Morgan or to me if you think of anything else that will include those. And then finally, we always ask about any engagement board members have done with members of their community, any requests for speaking or groups that would like to hear from us or get updates. Yes, go ahead, Jen.
Yes, I was invited. The date is not set, but in December, I'm organizing an international symposium. So my colleague in Taiwan knew I will be in Taiwan. And so the Taiwan Medical Association asked me to give a talk about the reflection on Taiwan's, next year will be the 70th anniversary of Taiwan's Universal Healthcare. And I just published a paper on the overview of that. But in that talk, I will potentially also be sharing about our experience, because Taiwan can also, we can learn from each other. We can learn from Taiwan's experience, and Taiwan can learn from our experience as well. Also, a quick comment. Earlier, Sarah mentioned about Medicaid. Oregon was the pioneer in the 80s to 90s. The out of the original OHP, the prioritized list. And that process was using the budget. And then we have a prioritized list, and we have the actuarially estimated costs. And so based on each biannual budget, we calculate to what priority that we will be cover that. And for that to implement, we had to, it took us, I think, 3 years to get a federal waiver, because we are kind of conflicting with the Medicaid requirement. That model potentially can help us reflecting on Warren's earlier comment about the taxation. Taxation is kind of our de facto global budget. And how do we, based on that limit taxation global budget, to set our benefit? So that Oregon was a pioneer in the world, and we can relearn that experience.
I've been asked to give an update on the board's work to the HCAO, Care Advocates of Oregon. They have their fundraiser this weekend. I'll be there doing that. And then I've also been asked, Warren and I were asked to give a update presentation to the Oregon Medical Association senior physician. Is that right? So those two things are coming up. Yes.
Michelle and I will likely sometime somewhere between October and December, Alliance for Healthier Oregon meeting, do a kind of update, but we'll talk about timing wise and agenda wise what's best. So it's a group of various organizations that have healthcare and social determinants related legislative agendas that we convene and they come together and share information with each other.
Who else? Okay, we have some public comments. I'll ask, Rich Walsh to start us off. Or continue to be engaged in our work, Mr. Walsh, that's great.
Thank you. Hello, my name is Richard Walsh. I've talked here before. I'm a local attorney. I've represented thousands of personal injury patients that have been involved in the healthcare system. I only have 2 minutes, so I'm going to try to make this very brief. I went to the Salem Art Fair. I was there at the HCAO booth, but I don't represent HCAO here today. But while I was there, I talked to about 100 people, and my idea that I talked about last time holds true. People will vote for this and support it if you can tell them your plan's going to be as good as the governor's and it's going to cost you personally less. Very simple message, and it works. It still works. One more element that I didn't realize before is there's this third element of trust. If it gets complicated or whatever, they just get confused and I don't want to get rid of my current plan, and then you lose them. And you have to have simplicity and trust. And that should be the overall goal as we go through. I want to emphasize the urgency that you have. The Oregon Health Plan, their committee took 2 years. They focused mainly on this party list that you were talking about. And it took 2 years. They had a lot of support and they did a lot of the work. We don't need to reinvent the wheel. I agree with what you said earlier. We have 2 plans we can pick from that are already basically done. We have the Oregon Health Plan and we have the Public Employees Plan. We should pick one of those. This board should pick one of those as a model and stop talking about the individual details about what service. I mean, the first committee took 2 years to talk about that party list. You won't have time to get this job done if you don't get a plan picked. Once you have a plan picked as the model, then you can study it. Then you can say, well, how much does it cost? How much does it cost per person? And if you don't do that, if you're going to try to design a plan and then figure out how much it costs, you ran out of time. It'll be hopeless. This will never work. You got to pick a plan that already exists. They've already done the work. Don't reinvent the wheel. Pick one of those plans and work with that. They already have cost containment measures in them. Trust them. Trust those plans. They've already been worked out. And then just adopt them and work on the real work you have to do, which is administer the plan. You have the Oregon Health Plan already set up to administer the plan. You just get finance the plan. If I could just say, finance the plan. There's 2 things: government. You got to gather all the resources together and figure out what you got, and then whatever's left, you got to figure out how to tax it. And when you tax it, it has to be less than the amount that they're currently paying. And if it's not going to work. And all this work is going to be for absolutely nothing. So you do the analysis of the government plan, the Oregon Health Plan, which would be a high watermark, is really great. And the government employee plan, which is less. And they have co-pays and deductibles and all the things like Taiwan had to do. And we will probably have to do something like that too. But try to do the Oregon Health Plan for everybody. But if it turns out that it costs individuals more when you do the financial analysis, then you can back up, but don't go below the Oregon Public Employees Plan or you'll lose the public. And I could talk about this stuff for an hour, but I'm out of time. Any questions? Thanks.
And next we have Mike Huntington. I believe he's virtual. Okay.
Mike Huntington, you are up.
Can you hear me?
Yes.
Yes.
My name is Michael Huntington. I'm a retired radiation oncologist from Corvallis. I'm here because I witnessed the tragedy of patients delaying care because of cost and limited access. I want to comment on the Growth Target Advisory Committee presentation. Sarah's presentation shows extensive data that can be valuable to the board if it helps achieve the primary intent of SB 1089. That intent is for the board to design a universal healthcare plan, financing, and administrative structure. Sarah's presentation seems to suggest, however, that a value-based payment system is a mechanism the board should consider. Is that true? Value-based strategies all involve shifting insurance risk onto fiscal intermediaries or care providers. The assumption is that upfront payment and acceptance of final financial risk will control cost and reward value instead of volume of services in healthcare. However, this assumption is ideological and not based on evidence. Value-based strategies have never achieved the triple aim of improving care quality, population health, and reducing cost. The dominant cost to control is administrative. Transitioning to a single risk pool universal health care, as SB 1089 directs the board to do, would eliminate the inherent costly gaming we see in fragmented, capitated, value-based systems. Gaming includes avoiding sick people and skimping on care. Value-based antidote to skimping on care is risk adjustment. Risk adjustment introduces a third game known as upcoding. We now have a Super Bowl game of games that none of us can afford to attend. While the data is presented as enlightening and valuable, it is beneficial only when used to design a universal healthcare system. A value-based payment system is ineffective and irrelevant to the universal system the board has been commissioned to design. Thank you.
Thank you so much for those comments. Any other thoughts from the board? Yes.
I just have a quick comment about using the OHP. That's the OHP already did a lot of groundwork, and that could be our foundation, and we can build on that. But I think what's important is whatever the benefit structure we design, we have to keep in mind they're not set in stone. They'll continue to evolve, and therefore it's important for our board to also develop, design the mechanism. How will those benefit structure be revised? Because as time goes by, technology change, disease change, they will need to be revised. So I think it's far more important for our board's responsibility to prepare the mechanism rather than the detail of the benefit, because the benefit can continue to evolve.
We have our final quote. This is from Amy, I believe. Go ahead.
Okay, so the quote that I picked is from a disability justice advocate, Mia Mingus. Understanding disability and ableism is the work of every revolutionary activist and organizer of every human being. Disability is one of the most organic and human experiences on the planet. We are all aging. We are all living in polluted and toxic conditions. And the level of violence currently in the world should be enough for all of us to care more about disability and ableism.
Any volunteers for next month's closing thoughts? And again, could be a quote, it could be just thoughts or an anecdote or a story from your community or from your own experience, just some sort of closing thoughts for us. Anyone want to volunteer for next month?
Bruce is really good at haiku.
Bruce, okay, okay, Bruce is up.
And Michelle had her hand raised, so maybe.
Well,
could be the
Michelle,
month after.
be my guest.
Okay, Michelle for October, Bruce for November.
Sounds good. You'll remind me.
Okay, okay. Okay, then I will adjourn this meeting. Thank you all so much. Thank you.
Thank you.
Who's the-